Thank you very much for the honor and pleasure of presenting our work on behalf of my colleagues and collaborators. These are my disclosures. So, as we've heard from our two previous presenters, the COVID-19 pandemic presented a unique and unprecedented in our lifetimes situation where we had reduced access to the operating room, with patients and physicians facing a dilemma of what to do with early stage lung cancer or oligometastatic lung malignancy. We were facing the prospect of having to delay curative resection for at least many months, if not longer. There was also the concern that our previous presenter elaborated upon about the potential risks of COVID-19 infection, both of contracting it as well as having a bad reaction once contracted with COVID-19 and thoracic cancers. And this risk, in my mind especially, was amplified in patients that had to undergo lung surgery in a situation where COVID-19 is a virus that has a pulmonary tropism. Beside that and alongside that, we were quite hopeful that and reassured that there was a local modality that, at the very least in the short and medium term, was proven to have quite good efficacy at local control for lung cancer and lung oligometastatic disease, and this is SBRT. So a group of thoracic oncology programs came together to create this protocol called SABR-BRIDGE, which is a protocol of offering SBRT or SABR as a bridge to surgery rather than just delaying until operating rooms became available or the safety was felt to be acceptable for doing lung surgery. The objective of this particular study report was to report and describe the surgical and pathological results from this approach. Eligible patients were enrolled from 4 institutions, mainly in North America, so 3 in Canada and 1 in the US, University of Michigan, McGill University in Montreal, Canada, Western University in London, Ontario, Canada, as well as the leading center, which was the University of Manitoba in Winnipeg, Canada. These were patients who had early stage or oligometastatic disease that would normally be resected, and these are patients that actually would have otherwise been resected and surgery would have been their first choice. They underwent SBRT and then had surgery about 3 months or more after SBRT. They underwent standardized IASSLC based standardized pathologic assessment. Pathological complete response, or PCR, was defined as absence of viable cancer cells on H&E. Major pathological response as less than 10% viable tissue. So 75 patients were enrolled, with 72 patients actually undergoing SBRT. 26 patients ended up having surgery, and the reasons for not having surgery are listed here. So 46 patients, the majority actually did not have surgery yet. 2 patients had metastatic disease and therefore did not undergo surgery. 3 patients had non-cancer deaths before surgery could be done, and in 13 patients, now it's 12, surgery is pending. And in 28 patients, based on patient choice and clinician choice, the decision was not to proceed to surgery for various reasons which we can discuss. In the patients that were resected, the pathologic complete response rate was about 50%, and the MPR was 73%. If you look at these baseline characteristics, the column over here looks at all patients within the cohort, and this column here looks at surgically resected patients. And essentially what you can see is that there's no significant difference between those 2 groups. I will draw your attention to the fact that about 57% of patients had pre-treatment confirmation of malignancy based on biopsy, and there's no difference between the 2 groups in that regard. Also, the tumor size was about 2 centimeters, and the majority of patients had adenocarcinoma of the lung. The most common treatment modality for SABR was 34 gray, or regimen was 34 gray in 1 fraction, followed by 48 gray in 3 to 4 fractions and 26%, and finally 55 gray in 5 fractions. So one of the really cool things about the study was that we were actually able to springboard and implement implement single fraction SBRT in a lot of the centers that were trying to implement. So a lot of positives that came as a result of this. There was one grade 5 toxicity related to SBRT. This patient passed away 10 days after receiving SBRT. The reasons for this are unclear. There were 5 grade 2 to 3 toxicities. And the median time to surgery is 4.5 months, with a range going from 2 to 17.5 months. Surgery was rated as being more difficult in about 38% of the cases, and the most common reasons are fibrosis and adhesions. There were 2 intraoperative complications, both PA bleeds requiring conversion to an open operation, but otherwise no other intraoperative complications. There were 8 post-op complications, and they were all grade 2, mostly prolonged air leak requiring conservative management, like pleurodesis or being sent home with a Heimlich valve. Interestingly, about 31% of patients had nodal disease found on resection, which was unanticipated. And 15% of these, or 50%, or about half of them, were M2 disease. The PCR rate varies, so the PCR is higher if you operated earlier. So there's about a 75% PCR rate if you resect within 3 months. It goes to about 50% if you resect between 3 to 6 months, and then it goes down to 33% if you resect after 6 months. So there's a lot to read into that, which I don't necessarily get into right now, but at least part of it is that is related to the selection of who gets the surgeries in some centers. So in some centers, patients were resected more likely if they had signs of progression. So this biases this estimate quite greatly, and it's important to understand that. The PCR rate was also higher if you had no preoperative biopsy. So 91% cure rate or PCR rate if you didn't have a pre-op tissue diagnosis, and it goes down to about 20% if you had an actual diagnosis pre-treatment. So what are the take-home messages? I think the biggest message for me and for our group is that this approach allowed us to offer curative treatment safely without delay in a time when we were very concerned about our ability to offer care to patients. And this did it without increasing health system burden and without increasing patient risk, with a purely outpatient therapy that was safe for them and allowed them, a lot of these patients, to be able to have enough time to get vaccinated and avoid those waves. The PCR rate was 50%, as we discussed. The limitation, of course, is that only 36% of patients were resected. And so the estimate, you can take it with a grain of salt, although you can make an assessment of this and say, well, there is a worst and best case scenario. So in the worst case scenario, you can imagine that anybody else who was not resected did not have pathologic complete response. In that scenario, the PCR rate, the true PCR rate, is 18%. You can have a best case scenario, and a little bit of a Pollyanna approach to it, if you wish. And if you assume that everybody who was not resected had a pathologic complete response, then the ceiling of the pathologic complete response is 82%. And so, as in most things, the truth likely lies somewhere in between and not at the extremes. And my suspicion is, and that of most of our colleagues, is that it probably lies closer to the 60 to 70% range. There's more data coming as more patients are resected, and we will have more mature survival and quality of life data. And I think with that, I will end. I'd like to thank our collaborators.